Hi everyone, and in this video we'll be discussing combined effect of the drugs. So what happens when drugs are combined? What effects do we see? It may be good or it may be bad also. Let us see. Number one, we need to understand when we combine the drug, there is a action called permissive action. Permissive action of the drug. You all know that steroids. So steroids have permissive action. So they have permissive action on adrenaline as well as noradrenaline. The meaning is, in the absence of steroids, adrenaline noradrenaline cannot produce proper response. So that is called permissive action. That's why a person who has less steroid or steroid absence cannot survive. Even though they have adrenaline noradrenaline, they cannot function fully. So that is called permissive action of steroids, which you have studied already in your physiology. The next important aspect is when we give the drug, you see the additive effect. So when we combine the drug, we can see additive effect. For example, 1 plus 1 is 2. Addition, that's it, simple. Suppose a patient comes with body pain. So we give paracetamol plus diclofenac. So here, the effect of paracetamol, the effect of diclofenac add up, that's it. There is nothing special in that. So patient will have more analgesic effect, that's it. The effect of paracetamol, diclofenac add up. That is why it is called additive effect. The third important effect when we combine the drug is synergism or synergistic effect. Example is when we give antiplatelet drugs like aspirin plus clopidogrel. So when we add them together, the antiplatelet efficacy increases. So we can write it as 1 plus 1, the action is more than 2. So the efficacy increases. Another example is an example called cotrimoxazole. Now cotrimoxazole is made up of two important antimicrobials. One is called trimethoprim and one more is sulfamethoxazole. So trimethoprim is static, sulfamethoxazole is static. When we combine them together, they become cidal and the effect increases. And they also produce something called sequential blockade. We'll understand that in antimicrobials. So remember the examples: aspirin plus clopidogrel and cotrimoxazole. The next effect is what we mean by potentiation. Now what do you mean by potentiation? For example, the drug produces a response of 1 and we add something which doesn't produce a response, but when we add it, the response will be more than 1. Sir, you are teaching mathematics, we are not understanding. So don't worry, we will make you understand. What do you mean by potentiation? Now we all know that we use levodopa in the management of Parkinson's disease. So where do you use levodopa? In the management of Parkinson's disease. Now why don't we use dopamine itself? Because in Parkinson's disease the problem is dopamine is less and we can give dopamine only. Why are we giving levodopa? Because levodopa can cross the blood-brain barrier, dopamine cannot cross it. So let us do what happens with levodopa. So when we give levodopa, levodopa is the one which crosses the blood-brain barrier. So this is the barrier. So let me write it as blood-brain barrier. So levodopa enters. But levodopa is metabolized to dopamine outside the brain as well as inside the brain. So outside the brain we have a decarboxylase called peripheral decarboxylase that will metabolize levodopa and dopamine, and in the brain we have central decarboxylase which will metabolize levodopa. Suppose if I give 100 drugs of levodopa, there is entry of 1 or 2 levodopa inside. Why? 98% of levodopa is metabolized dopamine outside. But in Parkinson disease, I want dopamine inside the brain more. So when I give levodopa alone, I am getting only 2 response. 2 drugs are entering. So what should I do? I should inhibit the enzyme peripheral decarboxylase. Now the drug which inhibit that is by the name carbidopa. So when I give carbidopa, now what happens? Levodopa entering will increase. For example, 10 to 12 will increase. So if 10 to 12 are going inside, more dopamine is formed and the efficacy of the drug increases. So more dopamine enters inside and the efficacy of the drug increases. So that's the point here. So the classical example of potentiation is the combination of levodopa. Levodopa has a response of 1. Carbidopa is not a dopamine prodrug, so it has a response of 0, but when we combine them, the effect increases more than 1. You can see here, 1 or 2 are going now, 10 to 12 are going. So this is an example of potentiation of the drug. When we combine the drug, what we see is potentiation. So until now we understood what are the important combined effects. Number 1, the permissive action. Number 2, additive. Number 3, synergistic. And number 4, potentiation. Fifth one, which we need to understand when we combine drugs, they can produce antagonism. You know that what is antagonism is the blocking property of the drugs. Now I can give an example. 1 plus 1, the response decreases. That is 1 plus 1 should be 2, right? But the response is less than 2. So that is antagonism. Now there are different types of antagonism. Let me tell you. Number 1, there is an antagonism called physical antagonism. Physical antagonism. What do you mean by physical antagonism? Suppose the poison is producing the adverse effect and the action of poison should be antagonized by someone. Who will antagonize the action? It is called activated charcoal. How does it antagonize the action of poison? It absorbs the poison and the poison cannot give the response. So it is blocking the response. How? By the physical method, that is adsorption. And that's the reason it is called physical antagonism. Clear? Moving on to the next antagonism, it is called the chemical antagonism. Chemical antagonism. What do you mean by this chemical antagonism? So there should be some chemical reaction and block the action of the drug. Let me take a physiological example, HCl. We know that HCl, when it increases the stomach, causes gastritis. And for that we use an antacid. For example, I have given already magnesium hydroxide. So this is an acid and the effect of acid is blocked by a base. And what you see is neutralization of acid. So this is an example of chemical antagonism. So what are the other examples? Let me give an example of heparin. So heparin is one of the acidic drug. And when I give an antidote for heparin, suppose when we give high dose of heparin, we have an antidote for that, and that is called protamine sulfate. The name is protamine sulfate. But protamine sulfate is basic in nature. And you know that when acid and base combine, again what you see is neutralization of action of heparin. Same thing we use chelating agents. We'll learn them later. So they can also act by chemical antagonism. So number 1 I told you physical. Number 2 I told you is chemical antagonism. What are the other types? The other types of antagonism are physiological antagonism. Physiological antagonism. Sir, what do you mean by physiological antagonism? Let me take an example here. Let me draw the bronchus here. This is the bronchus. Now, when there is adrenaline, before I come to adrenaline, let me tell you this concept. Histamine. Histamine is a allergen. So when histamine comes and acts on the H1 receptor in the bronchus, this is the bronchus. What does histamine do? It causes bronchoconstriction. Now, you have heard about anaphylaxis. The main problem in anaphylaxis is histamine acting on H1 receptor and causing bronchoconstriction, wheezing. Now, the antidote for that, the drug of choice for that is adrenaline. When you give adrenaline, it acts on the receptor called beta 2 and it causes bronchodilation. So, it will antagonize the action of histamine. But when do you call it as physiological? There are two important rules. Number one rule, the receptor should be different. Are the receptor different? Yes, this is histamine, this is beta 2. Second important thing is the response, what you see, they should be opposite. The response, what you see, should be opposite, and then we call it as physiological antagonism. So, bronchoconstriction, what is the opposite of that is bronchodilation. So then we call it as physiological antagonism. So let me repeat, when histamine is there, it acts on H1 and causes bronchoconstriction. To overcome that, we use adrenaline, which acts on beta 2, a separate receptor, and cause bronchodilation. So when do you call it as physiological? Receptor should be different and the action should be opposite. If you understood this concept, I will ask you one more example. You have to pause the video and answer that. So let me take the example of glucagon and example of insulin. Glucagon increases the glucose level, that is hyperglycemia. Insulin decreases glucose, that is hypoglycemia. So what is the antagonism between glucagon and insulin on the effect of glucose? Is it physiological or not? Think and tell me. Glucagon and insulin. Remember, insulin, just now in the previous video you would have understood, it acts through tyrosine kinase receptor and decreases glucose. Glucagon, if you don't know any receptor, ion channel, tyrosine kinase, that means it should be G protein coupled receptor and increases glucose. So what is the rule for physiological? The receptor should be different. Is it, sir? Correct. The action should be opposite. Yes, it is causing hyper. This is called hypo. So glucagon and insulin are called as physiological antagonist. Physiological antagonist on glucose. Correct. Once you understood this, I will ask you one more question. Let me write the same bronchus here. This is the bronchus. Bronchus. Now, there is a drug by the name salbutamol. The name of the drug is salbutamol. Salbutamol acts on the receptor called beta 2 and causes bronchodilation. Then we have a drug by the name propranolol. Propranolol, it acts on beta 2, blocks it and causes bronchoconstriction. The question here is it a physiological antagonism? Yes or no? Please think and tell me. No. Reason is receptors are same. Even the actions are opposite, the receptors are same. So what if the drugs antagonize on the same receptor? This is called receptor antagonism. So we'll discuss that. We'll discuss receptor antagonism next. The next antagonism we need to understand is something called receptor antagonism. Receptor antagonism. Now in receptor antagonism we have two types. One is called the competitive and one more is non-competitive antagonism. So let us understand that what is competitive and what is non-competitive. Let me write here. Competitive and one more is non-competitive. Okay, so what is the difference between the two? Let us understand here. What is the meaning of competitive? Let me write the receptor here. Now this is a receptor, this is a receptor. Now the drug has to bind on the receptor. Now this is an agonist. So agonist is trying to bind to the receptor, and there is one more antagonist. So agonist and antagonist both are trying to bind to the same site of the receptor, then it is called competitive. So if they try to bind to the same site, then it is called competitive antagonism. So in this competitive antagonism, the antagonist is coming and sitting on the receptor. Now what is non-competitive? Let me write the same receptor. This is the receptor. In the receptor we have another site, and that is called allosteric site. So here the antagonist binds. So the antagonist sit at allosteric site. Where does agonist bind? Agonist bind at a different site. So this site is called allosteric site. So the binding of agonist and antagonist are different. Remember the basic concept. If the drugs bind at different site, then the antagonism is non-competitive. See, they are not competing for the same places. Antagonist is binding at allosteric, agonist is binding at different site. But the problem is when the antagonist bind to allosteric site, it will not allow agonist to work fully. It will not allow agonist to work fully. That's the problem. So we understood the basic differences. Now, suppose in this situation the antagonist is sitting on the receptor. The antagonist is sitting on the receptor. Can we overcome this antagonism? Think, how can we overcome that antagonism? What we can do is we can increase the agonist concentration. When you increase the agonist concentration, it's a competition. Now who can take the seat? Whoever is stronger can take it. So when you increase the agonist concentration, they will kick the antagonist out and agonist sits there. That means you can get the same response, but you have to increase the agonist concentration. So here in competitive, by increasing agonist concentration, or what we call it as dose, you can get same response. You can get same response. So the term used for that is surmountable. You will get the same response. It is called surmountable. So what is response? What we call it as response? What is another term for that? Efficacy remains same. The efficacy remains same. What about non-competitive? Very, very important. Non-competitive. In non-competitive antagonism, the agonist is binding, but the antagonist is binding to some other site. So here the response decreases. The response decreases. So what do you mean by response decreases? The efficacy decreases because of the presence of antagonist. Antagonist will not allow agonist to function fully. So that's why the response decreases. Right? And here what happens to the potency? Potency of the drug remains same. But here the potency of the drug decreases. Why it decreases? Because you are using higher dose of the drug to overcome antagonism. So remember here the efficacy decreases, potency remains same. Here efficacy remains same, potency decreases. What is the example of competitive antagonism? Example is a classical example of acetylcholine and atropine. Now these drugs compete for the receptor called muscarinic. Now who can take up? Whoever is higher, they will take up. Suppose there is atropine poison. Atropine will bind to muscarine and it will block it. So atropine is an antagonist for this site. And acetylcholine is agonist for this site. So if there is atropine poisoning, that is atropine has blocked a muscarinic receptor, how do you overcome? By increasing acetylcholine concentration. Another classical example is morphine. Morphine is agonist at the receptor called mu. What is the antagonist for that is naloxone. So naloxone is an antagonist. Now this is vice versa. For example, morphine I have given excessively. And there is morphine poison. I want to kick the morphine out. Then you can use antagonist. That's why it is called competitive. Whoever is stronger or whoever is higher level, they can take up. And which one is important is examples of acetylcholine, atropine, morphine and naloxone. You understand that. What is the example for non-competitive? The example is the binding of certain drugs on GABA. So what I am talking about is GABA. Example is benzodiazepine and a drug called bicucolin. They bind to different site in GABA receptor. Now you pause the video and tell me which antagonism is better to prescribe or which is good for us. Competitive, because you can overcome competitive antagonism, but non-competitive antagonism you cannot overcome. That's the problem, because antagonists sit at different site. That's the problem. So let me repeat again. Competition means same site, non-competitive means different site. Now in competitive antagonism, you can get the same response. Only thing is you have to increase the agonist concentration. Non-competitive, the response decreases because the antagonist bind to different site. Even though the agonist increases, you are not going to get the same response. It will always decrease the response decreases. So competitive, the efficacy remains same, potency decreases because you are using higher doses. Here in non-competitive, the efficacy decreases, the potency remains same. The classical examples I told you, the acetylcholine atropine binding to muscarinic receptor, morphine and naloxone binding to mu receptor. The non-competitive are GABA-A, benzodiazepine and bicucolin classical examples. So that is the difference between competitive and non-competitive antagonism. So once you understood this, let me draw a graph for you and you have to tell me that. So this is the response, this is the dose. Now when we give an agonist, I get a response like this. When I give an agonist, I am getting a response like this. Now I added an antagonist. When I add an antagonist, I can overcome the antagonism and I get a graph like this. One graph is like this. And one more graph is like this. So let me write here. When we give agonist without any problem, agonist alone, then we get a response, that is the first graph. Suppose there is an antagonism that is called competitive antagonism. Now you can overcome the competitive antagonism by increasing the dose. By increasing dose, you are getting the same response. The response remains same, but only thing is you increase the dose. You can see the graph has shifted towards this side. Now in non-competitive antagonism, this is non-competitive antagonism. So here what happens? The response decreased. The response has decreased. So that's why it is non-competitive antagonism. So these are the different types of graphs which can be asked in your exam. So that's why I explained to you. So in this video, we discussed combined effect of the drugs. And in the last, I told you how to identify competitive and non-competitive antagonism. Simple. If the graph shift rightwards and parallel, see the graph has shifted rightwards and parallel, it is competitive. If the graph flattens, it is non-competitive antagonism. Please keep that in your mind. So these are the different aspects of combined effect of drugs. Thank you all.